Good morning, everyone. Thank you so much for joining us today for our Distinguished Speaker Series. We are so happy to have Dr. Sunwoo here with us, talking about a very interesting and important topic to all of us, sleep. What is a sleep doctor? And it's also an introduction to sleep medicine. So we're excited to have Dr. Sunwoo here. For those of you who are not familiar with the La Jolla Community Center, welcome. Thank you so much for joining us today. I'm Nancy Walters. I am the Executive Director of the La Jolla Community Center, and we are a nonprofit organization, and we serve adults and seniors. We provide programs and services daily. Right now, we're all virtual. However, we will be transitioning to a hybrid model soon. We are looking at a June 15th date to have in-person programming, so we're very excited. We hope that you continue to learn about the community center and about our offerings. So please visit our website. It's www.ljcommunitycenter.org, and you can find out about our programs and upcoming in-person classes as well. And please note that once we do return to in-person classes, we will be following all of the CDC and county guidelines. So we are excited about that. So before we get started, I'm going to tell you a little bit about Dr. Bernie Sunwoo. Again, a very important topic. We are all excited to learn a little bit about how we can improve our sleep. So about Dr. Bernie Sunwoo. Dr. Sunwoo is an associate professor of clinical medicine in the Division of Pulmonary Critical Care and medical director of sleep medicine at the University of California, San Diego. Dr. Sunwoo received her M.B.B.S, which is a degree in Bachelor of Medicine, Bachelor of Surgery, which is an international medical degree equivalent to an M.D. degree in the U.S., from the University of New South Wales in Australia with first-class honors. She moved to the United States in 2005, where she completed fellowships in both pulmonary and critical care medicine and sleep medicine at the University of Pennsylvania. Dr. Sunwoo has special interests in the evaluation and management of patients with rare and complex lung disorders, hypoventilation disorders, and coexisting pulmonary and sleep disorders. In addition, she is actively involved in medical education and scholarship and is currently the medical director of pulmonary and sleep medicine at UCSD. So I'm sure you will all have questions for Dr. Sunwoo, so please use the chat function at the bottom of your screen or the questions function as well, and we will get to those questions after Dr. Sunwoo's presentation. So please help me welcome Dr. Bernie Sunwoo. Thank you for being here.
Hello, folks. I was just telling Nancy, I can talk about sleep, but Zoom terrifies me. So I just wanted to give us, super thanks to Nancy, Barbara, and the La Jolla Community Center for allowing me to talk about sleep, because, it is one of our pillars of health along with diet and exercise. So knowing what happens during sleep and recognizing potential disorders in sleep is really critical to our overall health. Having said that, the field of sleep medicine is actually a pretty new one. So we've all been aware that sleep is, we all do it. It's critical. We understand the importance of it since the dawn of humanity. But it wasn't really till the 1960s where researchers started to be able to record what we call brain waves or electroencephalography, that we started to understand that sleep was in fact an active state. Prior to that, the perception was that sleep was traditionally a passive state that evolved mainly because of the lack of stimuli that was coming in at night. And so around this time, research in sleep really evolved. And in 1970, actually in the state of California was where the first sleep clinic was created, and that was at Stanford at the time. Like anything new, there were initially some teething problems, including reimbursement. But in the 1970s, two things happened. The sleep study, which is called a polysomnograph, started to be reimbursed. But in 1980, an Australian called Colin Sullivan invented this apparatus that we would come to know as Cpap, or continuous positive airway pressure, which we'll talk about, but is a treatment for a disorder called sleep apnea. So all of a sudden, we also recognized that there were potential treatments for sleep disorders. So around this time in the 1970s, we saw an explosion of clinical sleep medicine. And we started to see the emergence of professional sleep societies. In 1978, the sleep medicine certification examination was offered, but it wasn't until 2003 that the ACGME, which is our organization for subspecialty training, recognized that sleep was a formal training program. So 2003, that's less than 20 years that there's actually been a formal sleep fellowship training program available. So the reality is now that when you complete a fellowship, you can sit the board examination. And I bring this to your attention because you can actually get into sleep via one of many paths. And so when you end up seeing a sleep doctor, depending on which track we have taken, we may come from very different backgrounds. So traditionally, a lot of us before sleep medicine training programs were formalized came from a pulmonary background. But when you see a sleep physician, they may not be a pulmonologist, they may have an internal medicine background, they may be pediatrics, they may come with a neurology background, ENT. So just to highlight that, again, depending on who you see, we may have a slightly different skill set. But what is it that we do? So like the name alludes to, we basically see anything that pertains to sleep. But at the end of the day, that ends up being one of 6 main categories of disorders that are listed here. And obviously the goal today is not to do a comprehensive review of these sleep disorders, but what I wanted to do was really kind of give you an overview and a flavor of what we see so that you may decide if that there may be a problem that you or friend, loved one may need to see a sleep doctor about. Also, I wanted to try and answer some of the key questions that I tend to get in my clinic when patients come in. So I'm going to start with the first one here being insomnia. It is probably the most, or at least one of the most common things I see patients about. So insomnia has 3 criteria. One is you have to have trouble sleeping. And so that can come in one of many different flavors. For some people, it's troubles falling asleep. For others, it's trouble staying asleep. A lot of patients, it's both. And then some patients also complain of waking earlier than they wish to. And it has to happen despite adequate opportunity and circumstances for sleep. So for example, I have a teenager who comes to me, they can't say that, they can't sleep. And then when I talk to them, they live in a studio with 2 roommates. One roommate works nights. The other likes to do music and has always got the radio on. And so, of course, they can't sleep. So again, insomnia has to happen in the context of adequate opportunity for good sleep. And it has to be associated with impairment. So what I mean by that is, there's often a fixation on how much sleep we need to get, but the reality is that that's very variable. And so some patients come to me and they tell me they sleep 6 hours and they have absolutely no problems with that. They're not impaired by it. They don't feel sleepy. And in that situation, we don't actually call it insomnia. There's this entity called short sleepers. They may just naturally have an inherent tendency to sleep less. So when trying to have a concept of insomnia, it's important to have a perception of what normal sleep is like. So we now know that in adults, and I'm an adult physician, so I won't be focusing really on pediatrics today. So in the normal adult, it's been studied now that we basically rotate from wake to sleep, and sleep has 2 main phases, what we refer to as non-rapid eye movement or non-REM sleep and rapid eye movement sleep. And the average adult will go from wake through non-REM and cycle through REM sleep about every 1.5 to 2 hours, which is why REM sleep, which is often the time in sleep when we dream, tends to occur the second half of the night. Non-REM sleep is typically divided into stages 1 to 3 now, with 3 often referred to as delta or deep sleep. So again, here we see the traditional adult, it cycles from non-REM, the 3 stages, and again, REM every 1.5 to 2 hours. This is kind of, I find fascinating. So on the left are same phylogenetic orders of species with different sleep times, and on the right, different phylogenetic orders but similar sleep times. So again, in humans, the average adult, we say, is about 7 to 8 hours of sleep, which is again very different depending on what species you are. But what I wanted to highlight is that, again, there's a lot of individual variability. And more than that, unfortunately, like everything in life, as we age, our bodies change. So if you look at a newborn, their sleep pattern is very different from what you're doing. So here I've listed a 20-year-old's typical sleep pattern versus a 60-year-old. And the top here is total sleep time. So we do sleep less as we get older. And the amount of time we actually spend in bed sleeping compared to the total time in bed is reduced. It takes us a little longer to fall asleep as we get older, but we actually go into the dreaming stage of sleep a little faster. And you will see that our proportions of the different stages of sleep changes as we get older. We tend to have less dreaming and what we often refer to as deep sleep as we get older, and more lighter stages of sleep. So this is normal. So again, like so many things, our sleep does change as we get older. So this is important again because having an understanding of what normal sleep will affect your perception of how you sleep. But bottom line is insomnia is common. And for all of us, we will experience insomnia symptoms at some point in our life. And that's okay. For example, right now it's COVID. We just had an election. You know, there's so many things that affect your sleep that's related to stress, personality, that I'll come to. So we've all been in a situation where we don't sleep as well. And again, it's really starts to be more labeled as a disorder once it's happening on a regular basis for a sustained period of time. So insomnia really now is thought of as a multifactorial and comorbid disorder. So it's often seen coexisting with other conditions. It's more common in women. There's a lot of debate about the impact of age. There's often a family history. And again, there is a strong association with certain personalities and stress. And so generally, patients who tend to worry, so so-called warriors, tend to have more difficulties with insomnia. And traditionally, we used to think of this model, it's called the Spielman's 3P model. So often there's a predisposing personality trait. There may be a precipitating event. So say COVID, all of a sudden can be something that, triggers it. And then it can be perpetuating, often with certain cognitive components. So the classic story in patients who can't sleep, it used to be called psychophysiological insomnia. So this may sound familiar to you. So what happens is that the patient starts to have trouble sleeping. So they go to bed, and when they wake up and they know that this has happened before, they know that they have to be somewhat functional the next day. So they worry about it. And the whole worrying gets the mind going and perpetuates the problem so that they can't fall asleep. So it's a bit of a vicious cycle. So if this sounds familiar to you, I know it's unpleasant, but it is a very normal response. And again, I can't stress the importance of the bidirectional relationship between sleep and also psychiatric disorders. So there was one study that showed that almost 80% of patients who have depression will have some insomnia. And in fact, it's actually one of the criteria for diagnosing psychiatric disorders. And so some patients, it's not just stress, but now it's at a point where it's more significant anxiety or depression. And usually I have to make sure that that is also being addressed to make sure that the sleep also will improve. So a lot of patients come to me with insomnia requesting a sleep study, but really a sleep study is only indicated if I have concerns that there's another sleep disorder also at play. Most of what I get when I try to evaluate insomnia is just by talking to you. Just to remember, if your doctor doesn't order a sleep study, there may be a reason they're not ordering it. Treatment of insomnia is very personalized and it's quite involved. It's directed not just at the sleep complaints, but a lot of those factors that I've talked about, because again, it's often a comorbid condition that are contributing to the insomnia. But the first line of treatment, and the thing I wanted to convey today, is that it's not actually any medication, but something called cognitive and behavioral therapy for insomnia. We abbreviate it as Cbti. There's a whole array of medications out there. As you can imagine, this is a big market because I've just told you how common difficulty sleeping is, but as I'll come to, there's not a lot of long-term studies for them. So again, Cbti is our gold standard. It's being shown to be as effective, if not better than any drug therapy without the side effects, and the benefits are more sustained than any pharmacologic therapy. There are two main barriers to it that I see. One is access, and that's going to be a recurring theme, but it's done usually with a sleep psychologist, and they are sometimes quite hard to find. And the other thing is there's a lot of skepticism from my patients that it may work. So people think of it as talk therapy. A lot of people equate Cbti with just sleep hygiene, which I'll talk about, when they're quite different. And so I have to just make sure I explain that what it entails. I'm not going to go into it at length today for time purposes, but it's generally 6 to 8 sessions with, again, a sleep psychologist, and they will work with various techniques. The most effective is something called sleep restriction. They will actually limit how much time you spend in bed. So during the actual process, you can feel actually more sleepy. And so it's important to recognize that it's like any behavioral changes like quitting smoking. It does take effort and it takes a little time. So sleep hygiene, I really can't give a talk without mentioning it, but I just wanted to stress that while it's important, the studies looking at it have actually shown that it alone is not effective for long-term benefits insomnia. But again, we have to be aware of it. So there's a few things that we always as sleep physicians recommend. One is your bed should just be for sleep and sex. So anything that you do around bedtime should not be in that bed. If you read, we recommend doing it outside, even if it's a chair in the bedroom. No working in the bed, no eating in the bed. And the bedroom should be quiet, dark, and cool. We don't recommend it to be very warm. It should be a cooler temperature. Sleep-like schedules. So the more regular your wake time and bedtime, the better. And caffeine, everyone has variable sensitivity to it, but generally we recommend trying to limit it before noon. One thing we do talk about is trying to avoid super stimulating activities just before bed. I used to include physical exercise in this, but there's actually more recent research that probably doesn't matter. And so I don't actually give that advice anymore. It's probably fine to exercise before bed, but what they have shown is that exercise earlier during the day does have more benefits. And then no clocks. So this is an old, I feel like no one even has clocks these days, but you want to try and avoid looking at the clock in your bed. And you also want to avoid naps. So if you nap, it will take away from what we refer to as your homeostatic sleep drive at night. So you want to try and avoid that as much as possible. So again, these are really good tips for sleep. But if you're having troubles with insomnia, just be aware that this cognitive behavioral therapy is beyond this. So, you know, a lot of us want just a magic pill. You know, that's great, doc, but give me something just to take to make me sleep better. But the reality is that the data looking at sleep aids, there's not a lot of long-term data, and certainly not a lot of data comparing all these medications out there with potential side effects. So what I will show you is that the data shows that the effect sizes are very modest at best. So a lot of patients are surprised when I tell them, you know, actual studies show that it improves your sleep by only, you know, 10 minutes. So my general approach is, again, medications may sometimes be needed, but I generally try to avoid long-term use of these medications. And again, as I mentioned, there's a lot of medications out there. The choice is usually dependent on a number of factors, including the duration of the meds, what complaints you're having, other medical conditions you have. So it's again, factoring in many decisions with your doctors that takes into account the whole picture. I do want to briefly discuss the main sleep aids because a lot of you may be on them. There's a class called benzodiazepine receptor agonists, and they include traditional benzos, things like Ativan. You may have heard of Restorol, Valium. Dalmane was the old one, but it's really long acting. And then there's what we call non-benzodiazepine receptor agonists. We refer it to as Z hypnotics, but they're often commonly used. Many of you may have heard things like Ambien, Lunesta. The reality is, again, these have side effects. And I generally don't use benzos, especially in my elderly patients, because they definitely have side effects that I think outweigh the benefits. And one concern is also an association with cognitive impairment. And so they can help the time for you to fall asleep. But just as I mentioned, the effect sizes, the mean improvement is just 22 minutes with these. So these are not, you know, huge effect sizes at the expense of significant side effects. There are a class of antidepressants which are sedating at lower doses that may be used, but again, they have side effects. I wanted to just mention melatonin because it's like used like candy now. One of the problems with melatonin is it's not FDA regulated, so it's available over the counter and there's no real regulation of the formulation. Melatonin is a hormone that's produced by something called the pineal gland in our brain, which is involved in regulating our, what we call our circadian rhythm, our biologic clock, which I'm going to talk about a bit later. And it's produced in the dark cycle at night. The data for melatonin is actually pretty weak. The effect size is very small. So it's very short acting, number one. And when I say effect size, the studies have shown that it may help you fall asleep by about 7 minutes. So again, not huge effects. Having said that, we do think the side effect profile is probably better than many of the prescription medications. But I caution you on that because, again, because there's no FDA regulation, my experience is that I've seen patients come taking very high doses where we don't know, we don't have the research of the long-term effects of it. And there's some data that it may actually have effects on, say, hormone production. And so generally, you know, if you do use it, we recommend what may be perceived as tiny doses, you know, 0.5 milligrams. There is something called Belsoma or suvorexin. It's what we call an orexin antagonist. I'm not going to really go on this, discuss this in detail. At this point, you've really tried other medications, but this targets a slightly different brain peptide called orexin, which is implicated in a sleep disorder called narcolepsy. And then most patients who've had experienced insomnia have come to me having tried many different over-the-counter sleep aids. And, you know, this is just a sample here. But the reality is there's not a lot of data for it. And you can see that if you look at the active ingredient, basically most have something called diphenhydramine, which is Benadryl. And Benadryl has side effects, including, again, these are sedating, so you can have a hangover effect with any of these sleep aids. But again, they can be quite drying, and so I don't generally recommend long-term use of these either. So shifting gears a little, I mentioned this concept of a body clock. So there's a whole group of sleep disorders where we have a body clock, and if it's not in sync or if it's disrupted, it's referred to as a circadian rhythm disorder. So just to highlight this body clock, this was a really cool example. It dates back to, I don't even know where it dates back to, a long, long period of time. But there was this plant, it's called the Mimosa Padika plant, for those of you interested. And what they found was that the leaves open up during the day, and at night, the leaves shut down. And the thought was that it was the sun that was doing this, and in the nighttime, you know, that's why the leaves opened up and shut. But they did an experiment where they put the same plant in a box where it got no perception of light and dark. And even still, the leaves still opened up and the leaves still closed down. So this pointed to this notion. This was the beginnings of this concept of we all having a body clock or circadian clock. And in humans, that circadian clock is generally generated by something called the suprachiasmatic nucleus, which is again an area in the brain. And our body clock is actually about 24.2 hours. So pretty much well in line with the Earth's rotation and their light-dark cycle. And so normally our body clock is entrained to the 24-hour light-dark circle, which is defined by Earth's rotation. And the biggest things that trigger it are sunlight and darkness. And so when you have a circadian disorder, it's basically when your body clock is no longer aligned with the external clock, or there's some disruption. So classic examples of this you may have experienced are shift work or jet lag, right? It's shift work, your body clock likes to go to bed when the sun goes down and likes to wake up when the sun goes up. But now all of a sudden, you're forcing your body to do the exact opposite if you're a night shift worker and you feel pretty lousy. Similar, if you fly across time zones, and you'll notice the more time zones you fly, the more lousy you feel. And that's because, again, your body clock is trying to fight against a greater change in the external stimuli that you're getting. Delayed and advanced sleep-wake phase disorder is just fancy terms for night owls and early birds. So there are certain people who like to go to bed late and wake up late. So they like to go to bed, say at 3, 4 in the morning and wake up at noon. And it's not a problem. It's that society usually has expectations that you function at a certain time of the day. So this is relevant in that some patients come to me saying they have insomnia and can't sleep. And after I speak with them, what I really get is it's not that they can't sleep, it's that they can't sleep at society's expectation of you going to bed at a certain time. And in this group, if you give melatonin, which I mentioned is that hormone that's produced in the dark cycle at the wrong time, you can actually make things worse, which is why melatonin, I know it's out there, but there is a scientific basis for it, and there may be potential harms depending on how you take the medication. The best way for a sleep doctor to get a sense often is with what's called a sleep diary. They'll just ask you to kind of plot what you're doing in terms of your sleep and day. And what we often find is when we look at it, so in myself, I'm not a good example, I'm sleep deprived, but in for example, a night owl will see that everything is shifted, and in an early bird, everything is forward. In blind people, again, one of the biggest cues to keep us aligned is light. So if you lose the ability to perceive light, we see a very unique pattern. So your doctor may ask you to complete a sleep diary. And then the other big category that we see is the sleep apnea category. So obstructive sleep apnea is a condition where your airway gets too crowded when you sleep and makes the and basically interferes with the smooth movement of airflow in and out of your lungs. So in all of us, when we sleep, we have some degree of narrowing of our airways, which is why we snore. Snoring is basically the air's trying to get past your soft tissue and it's crowded and it causes it to vibrate. But in some people, it can be so crowded that air can't get through. That's referred to as an apnea, or it just gets through, but it's reduced airflow, and that's called a hypopnea. And if this occurs repeatedly during the night, that's referred to as obstructive sleep apnea. And it's common. A lot of patients have it, but don't recognize it. Again, like most things, it tends to be more common as you get older, although it does seem to plateau when you hit your 7th decade. Unlike insomnia, this is more common in men. In women, it tends to occur more commonly after menopause. And weight gain is one of the biggest risk factors, but not the only risk factor. So again, many of my patients will say, I'm not overweight, I don't have it, but it's not everything. For example, in Asians, we know that it's less so obesity that plays a part and more so the craniofacial anatomy. And it matters because, number one, your bed partner can worry about you. So many patients come to me not because they have any complaints, but because their bed partner is worried about what they're hearing at night. And we joke about it, but I have had patients who have serious concerns about, their marriages because they're worried about it impacting their bed partner's sleep. But the individual may experience sleepiness during the day. And the other concern is that if it's severe, it can be associated with other medical conditions. And so your primary care doctor may ask you to do a sleep study if you have one of the conditions that can be associated with sleep apnea. And the most common is probably high blood pressure, but also all cardiovascular disease, including atrial fibrillation and irregular heart rhythms, heart failure. There are associations with sleep apnea. There's associations with stroke and sleep apnea. Road accidents are about 2 to 3 times more common in patients with sleep apnea. So one caution I have is that, sleep apnea is an active area of research, and we're finding that it can be associated with many things, but it's not associated with everything. So I have some patients who say, I think this is a sleep apnea. And again, yes, some certain things definitely have been associated with sleep apnea, but the association is stronger for certain disorders than other disorders. So I kind of mentioned it. What may you experience? Again, snoring is common, but what patients often tell me is that, again, they hear snoring and then they'll hear pauses, so apneas, and it's often followed by like a gasp or a snort. And again, patients may feel sleepy because this is repeatedly happening at night, or they may actually complain of the opposite and poor sleep. So I mentioned that you don't always need a sleep study for insomnia, but if I had a patient give me a history suggestive of sleep apnea, then absolutely you may need a sleep study. You may actually complain of peeing too much at night, morning headaches, and then your mouth may feel dry. But at the end of the day, we know that doctors aren't able to accurately diagnose whether you have sleep apnea or not just by talking to you. So you need to do what's called a sleep study. And a sleep study will calculate something called the apnea-hypopnea index. What is the apnea-hypopnea index? It's basically, we will count how many times per hour on average we see limitation to the airflow moving in and out. So this is, there are two main types of sleep studies. This is what all sleep studies were traditionally. They were referred to as polysomnography. And I've put a photo, I came in this morning and took a photo of our sleep lab. I am suspecting no one slept in this bed overnight, otherwise they were very still. So for those of you who have been at our clinic is a clinic at day, and at night it transforms into our sleep lab. So this is a Murphy bed. So what it entails is you come for one night and sleep with various monitors on you. There will be monitors on your head, monitors on your face that look at airflow. As you see here, there'll be a band around your chest and your belly that looks at your breathing effort. There'll be an oxygen monitor on your finger, and then a few limb monitors. And all of this gets recorded. And I don't know if you see here, but there's a video. This is actually a TV, so you can watch TV, you can do whatever you want, but there will be a video because certain disorders, we like to see what's happening. And it generally is a one-night study. There is now the option of doing it at home, and there's many, many different types of home sleep studies, but they all vary. One important thing about the home studies is they won't record the brain or the eye, and you need those two signals to detect if you're in sleep and the different stages of sleep you go into. So some of my patients will want to know how they slept. You won't get that information from a home sleep study. But I will also say, you know, when you are in the lab in an unfamiliar setting with a zillion things on you, that's not the best way for us to assess sleep. So our main role for sleep studies is to see if there's another sleep disorder, but not really to tell you if you slept and what stages of sleep you go through. And just to give you a snapshot, this is the raw data from one in the lab and one at home, and you can see the amount of information is quite different. So sometimes if you have a home one and it's still equivocal, we may suggest you do one in the lab. A lot of patients come to me asking about all the new consumer wearables that are out there, and it's overwhelming. There was a study trying to look at these different wearables and how accurate they were in their claims. You know, they claim they can do all sorts of things these days. And the reality is that there's not a lot of data comparing certainly not a lot of data comparing them to each other, but to really look at accuracy, we often have to validate it to, you know, the one done in the lab. And the reality is that there's not a lot of data for that. So it's overwhelming. And so when you come to me asking about it, there's some data for certain things, but the reality is a lot of the data is not there, that we may not be able to tell you how accurate it is. The one other danger of these devices, I'm not sure danger is the right word, but if you are having trouble with insomnia, sometimes you can become a little fixated on these numbers. And so I actually try to take my patients, move away from it and not being so fixated on a single number. So again, your sleep study will generate the number of times they see you blocking and give you a sense if you have apnea and how bad it is, that we will decide if we need to do something about it. And again, sleep apnea, there's a whole range of how bad it can be, and not everyone needs to be treated. So a lot of the patients tell me, well, I don't want to do a sleep study because I don't want to use that device. But again, you may not need to use that device. Our choice of whether we offer treatment depends on how bad your sleep apnea is, as well as what other medical conditions you have, as well as any symptoms you may be experiencing. Cpap is our most common treatment. It stands for continuous positive airway pressure. And, you know, this was our very first CPAP unit using some like upside down vacuum device in Australia, but you can see that we've moved a long way since then. And all these devices they're pressure devices. So they blow air, it's not oxygen. And the notion is that air keeps your air passage open and prevents those blockages from happening when you sleep. I actually, at the back of my office here, I have some, so patients always ask me, how big are they? Well, this is how big they are. These are the two main brands. I've included the three main brands in the US. They all come with a water chamber or a humidifier to provide some moisture. And again, the noise of these, that's the other common question I get. It's not like what the CPAP devices used to be back then. It's white noise, so it will get rid of snoring. So usually most bed partners are happy because now they don't have to hear the snoring, and the noise is generally not an issue. Really, what's more important than the machine itself is the mask. There's many different types of masks out there. So everyone asks me, what's the best mask? But every face is different. So it really depends on the individual. The three main types are nasal masks. I have a head. So I'm in my clinic right now. So this is a nasal mask. This is just one example. It just covers the nose. And then again, within nasal masks, there's many different types. This is what was called pillows. So they sit under the nostrils. And then there's ones that cover the nose and mouth. Generally, there's some data to suggest that if you use one that covers the nose or mouth, it tends to maybe lead to better adherence or usage and lower pressure requirements. But my experience is it really depends on the individual. Some people have facial hairs, which affects seals. Some are true mouth breathers. So generally, you know, you may need to try a few masks, but getting the right fit of the mask is usually the key. And it only works if you have it on. So it won't do anything if you have it by your bedside, just turn on. It does need to be on. Many of you may be familiar that insurance requires a certain amount of usage for coverage, which I just wanted to bring your attention to, because sometimes you may think, why does my sleep doctor need to keep seeing me? And it's because unfortunately insurance does have some requirements, but it's not the only treatment. So again, a lot of my patients come to me going, I don't want to be tested because I'm never going to use it. And again, it's very effective, and I have many patients who love it, but I do have some patients who hate it, and that's okay. I will work with you to try and work out what you hate about it, if I can make it more comfortable. But sometimes, despite me trying multiple masks, trying different pressures, I find it difficult, and we have to look at other options. And the take home is there are other options out there. The second most common is probably what we refer to as an oral appliance. These are fitted by dentists, not by sleep doctors. And there's many oral appliances out there, but you want to make sure that this is fitted by a dentist who's trained to do an oral appliance for sleep apnea. Not every dentist is. Most of them are what we call mandibular advancement devices, meaning they tend to be upper and lower retainers. And what they are designed to do is bring the lower jaw forward, basically to open up your air passage. It's not quite as effective as CPAP. So if my patient has really horrendous sleep apnea, it's probably not the first thing I offer. But certainly if you have more milder, then it may be an option. But again, it depends on the individual. A few words in surgery is generally it's not first line, and hopefully I've conveyed to you it really depends on the individual and anatomy. Many of you may have heard of the UPPP, or the uvulopalatal frenuloplasty, which is basically shaving that uvula, which is a dangling thing at the top palate. But the success rate for that is very variable. Unfortunately, the most effective surgeries tend to be very invasive. So the most effective is something called maxillomandibular advancement, where they crack the lower jaw and bring it forward, but obviously very invasive. So it's not our first line. One other thing that you may hear about a lot, I find when I try to drive in from work, is there's a lot of marketing for this thing called a hypoglossal nerve stimulator. What it is essentially is a pacemaker to your tongue. So they implant something under your skin, and they will put an electrode that sends pulses to try and bring your tongue forward. Again, more invasive. But again, bottom line is there are other treatments apart from Cpap that your doctor can talk to you about. And there are certain things that we always recommend, and this may help those who just snore but don't have sleep apnea. So weight loss, you want to avoid things that make things worse, and that includes anything that makes you more groggy and less muscle tone. So alcohol, so you may find that when you drink or have a drink, you snore more that night. Position can matter in some to a greater extent than others. So people tend to have less sleep apnea on their side, and that's just because of pure gravity. So on your back, everything kind of drops back, and sleeping with your head of bed elevated may help. And also if you have a lot of nasal congestion, so people ask me, well, if I use that, will it help? Generally, it may help with snoring a little bit, but sleep apnea tends to be just not just behind the nose, but more behind the tongue and the palate. That usually that alone isn't helpful, but it will be very helpful for you trying to get used to any mask that you're wearing. This is just a positional pillow that I've included. This is the FDA regulated one, tries to keep you sleeping on your side and not rolling on your back. But you can find many on Google. The old thing was on Amazon. The old thing was, you know, we used to sew tennis balls on your nightgown at the back so you didn't roll back. I put this slide just to highlight that there are other forms of sleep apnea, specifically something called central sleep apnea. So there may be a small proportion of you who end up seeing a doctor for sleep apnea, and it's a different type of sleep apnea. So just to be aware that that may happen. So I'm pushed for time, so I'm going to just kind of highlight maybe two other things that I get common requests for. One is this whole category of movement disorders, and really under that, the two things I see are restless legs syndrome. The real name, or the preferred name for it now, is Willis-Ekman disease. It's common, and it's a pure clinical diagnosis. So people with restless legs often have trouble describing it, and they often end up using their hands like I am. But what they describe is that they have this discomfort in their legs. It's kind of like an angst. They feel like there's ants under their crowing, like a Pepsi type bubbling. But what they want to do is just kind of move their legs. So there's an urge to move the legs. And it happens at rest at night. So if this is happening, you know, during the day, that this is probably, it's not restless legs. And they get relief by moving their legs. This is very different from leg kicking. So leg kicking we call periodic limb movements. Now, most people with restless legs will also have the leg kicking, the periodic limb movements, but periodic limb movements are very common. They probably most times are not anything to be worried about, but some of my patients come to me saying they have restless legs, but when I really talk to them, what they're really describing is that they have this leg kicking or periodic limb movements. Restless legs is more common in women, and it is associated with iron deficiency. So one of the things we do recommend is talking to your doctor about getting your iron levels up there. There are medications for restless legs. In the sleep community, we've changed our tunes a little. Traditionally, it used to be a class called dopamine agonists. So they're things like ropinirole or pramipexole, so Requip and Mirapex. The reason we changed our tunes is we realized that there was this phenomenon called augmentation. So what we mean by that is we realized if you start taking the medicines a lot frequently, it could actually make the restless legs worse. So some patients have been started on these medicines. They don't have their leg symptoms under control, so they'll self-increase the dose and what they're actually doing is potentially making things worse. So again, we've now shifted to the gabapentin class of meds as our first line, but just be aware, if you have problems with this sensation, certainly see a sleep doctor and we can talk to you about it. And then I'm just going to shift gears and mention two other things. Parasomnias are undesirable physical events or experiences that occur during sleep. These include sleepwalking, night terrors, confusional arousals. These are really seen in kids, so I'm not going to talk about it, but I did want to mention something called Rem Behavior Disorder. Along these lines, a lot of people come to me saying they talk in their sleep. We don't worry about that. Talking in your sleep is, it happens, and it's not associated with pathology. Rem behavior disorder, these are the stories that you may have heard of, like the husband kicking their wife, acting out, fishing at night. So in REM, which is the rapid eye movement, the dreaming stage of sleep that we talked about, normally our body is in a state of atonia. So what I mean by that is our muscles are essentially paralyzed, that we don't act out our dreams. But in patients with REM behavior disorder, they lose that loss of muscle tone, so they start acting out their dreams. This is mainly seen in elderly males. And so that's why the bed partner is usually the one bringing it to their attention, because they can't sleep because, you know, the husband keeps trying to, you know, hit them at night. Unfortunately, this is often associated with neurodegenerative disorders. The classic one is Parkinson's disease. So if you or your loved ones have problems with where you think they're acting out their dreams, please definitely talk to your sleep doctor and see if you can be evaluated for it. And then the final class that we see patients for is something called hypersomnolence, which is sleepiness. But pathologic sleepiness. So I am right now hypersomnolent, but it's because I'm sleep deprived and it's a normal response. But there are some patients where the hypersomnolence is beyond normal. And the classic example of that is something called narcolepsy. Narcolepsy is largely thought to be due to loss of a certain type of brain neuropeptide called orexin. And so people with narcolepsy complain of feeling very sleepy, and they may have what we call features of the dreaming stage or REM intrusion. So cataplexy is a phenomenon where they lose muscle tone. They don't lose consciousness, but it can be subtle. In kids, it's often the face that loses muscle tone, but in adults, it can be subtle. They can, you know, their head can give way. It often occurs when you're emotional with positive emotions. Sleep paralysis is a phenomenon where you're waking out of sleep and you feel like you can't move your body, like you're stuck. It can be quite a terrifying sensation, and it alone, many of you may have experienced it, may signify nothing, but sometimes when it's frequent and happening with other symptoms, it may signal something to look to a sleep doctor about. And then occasionally some people can have dream-related hallucinations. So again, a narcolepsy is characterized by these symptoms, and it's thought to be due to a deficiency of the orexin, which is a wake-promoting peptide in the brain. So I'm going to apologize, this is too long, but I will just say right now, you know, I think there's many things that are changing in the whole field of medicine, not just sleep medicine. Certainly COVID has plunged us into this video world that we're doing, and our society has changed. We are our 24-hour society, and it's created some problems as well as some, you know, benefits. And access has always been one of the challenges to sleep medicine, which is why sleep medicine was actually one of the first fields to really engage in telemedicine even before COVID hit. So I will say that hopefully I've given you a flavor of what we do, when you might want to see us. And this is our team at UCSD. There's obviously many sleep programs out there. But again, just to highlight our very multidisciplinary nature, Dr. Owens or Dr. Malhotra, Dr. Klein have all pulmonary background. Dr. Dokart has internal medicine. No, she has a critical care, but not a pulmonary background. Dr. Schmickel is internal medicine. Dr. Orff is a sleep psychologist, and Dr. Leppi and Dr. V, as we call him, are ear, nose, throat doctors. So again, a wide background. So I'm sorry I went over time, but I have some time, so definitely take any questions.
Wonderful. Thank you so much, Dr. Sunwoo. Wonderful information. I'm sure everyone has benefited a lot from just participating. So there are a few questions. One is, it was gone through very briefly. Can you explain the difference between central sleep apnea and how does it differ from obstructive sleep apnea?
Yeah, it's great question. So anapnea just refers to no airflow. So nothing being sensed in terms of movement. In the sleep community, it has to be at least 10 seconds for what it's worth. So obstructive apnea, there's no airflow because there's blockage. And so if you look at the patient's respiratory effort, they're still trying to breathe, but nothing can get past because it's too crowded and blocked up. In contrast to central apnea is there's no airflow that's being sensed, but this time it's because the patient isn't initiating the breath. There's just nothing that's happening on the effort side to make them move air in and out. More commonly, this is usually due to some medical condition. So the most common is heart failure. Most patients in the hospital with heart failure, especially if they're decompensated, I will see some degree of central sleep apnea. Unfortunately, the other main cause that we see it is narcotics. So the treatment for central sleep apnea is usually because it's associated with a medical condition or drugs. We try and treat what's driving it rather than slapping Cpap on, although there's some data that may work. So usually, again, I would say most of it is usually due to a medical condition or narcotics, but it's just a difference of mechanism in that it's poor respiratory effort rather than blockage.
Great, thank you. We do have some more questions, but it is 11 o'clock, so I just want to thank everyone for joining us. If you do have the time and availability, please stick around. We will go through a few more questions with Dr. Sunwoo. So an additional question is, let's see. I often wake up with severe leg cramps that freeze the leg. It's very painful. Is this related to restless leg syndrome? And what do you recommend for cramps?
So in about 20% of patients with restless legs, there can be pain, but usually there's other symptoms with it. So if it's just cramps and muscle pain alone, then usually that's not restless legs. Again, restless legs is very circadian. It happens really just at rest in the evening, and it's really associated with this urge to move the legs, and you get relief from it. So if you're not getting relief from it, again, probably not just restless legs and maybe more cramps. Now, you can't have both things happen at once. Usually if it's cramps, I defer a lot to the primary doctor because you want to make sure that there's nothing medical driving it. For example, are your electrolytes out of whack? The treatment for restless legs and cramps is very different. We do recommend some behavioral things. So in restless legs, sometimes both warm and cool compresses, stretching exercises. Some people take baths before, but that's generally what we recommend for intermittent restless legs prior to going to medication use.
Great, thank you. Another question, Dr. Sunwoo, is what are your thoughts on CBD as a sleep aid?
You know, I had a premonition that was going to come up because, you know, it is California. So I actually did create a slide. I had a slide on some other things that might come up. So bottom line is the studies on cannabinoids and sleep are very mixed. There is some data that in patients who are naive on cannabinoid products that it may help you fall asleep and reduce the amount of time that you're awake after sleep. But there's also some data, especially if you've been on it long term, that it can make your sleep worse. So I think the data is very mixed, that it's not routinely recommended for a sleep aid. Now, there may be other indications for you using cannabinoids. For example, I know there's some data in seizures and pain. And again, I would defer to your primary doctor if there's other indications, but routinely, I don't use it as a sleep aid. There is also a real phenomenon sometimes in patients who are dependent on cannabinoids and try to come off it and go into withdrawal, that sleep is definitely impacted. So I've had some patients who, when they try to come off it, their sleep is affected they're in withdrawal. So I would say the data is mixed. I don't think long-term data supports, well, I don't think that there's a lot of long-term data, but I can't say that right now the data supports long-term use.
Great, thank you. An additional question is, I have used a Cpap since 2012. Since technology has changed, should I get another sleep study to see if my AHI of 17 has improved, or possibly a mandibular device?
It's a great question. So I think there's several things to that question. One is if you just want a newer device, some patients want a new device. In the past, the insurance every 5 years used to give you one. Now they're, depending on your insurance and DME, they kind of shifted away from that. I will say the devices can kind of look prettier. Maybe it's the color that you want. But to be honest, the devices function the same. I don't think really there's been too many changes. What has changed is the masks do continually change. And I have to say, the masks, while they may look prettier, may not always function the same. And so I have some patients who really like the older models, and they're just not produced, and you have to go online. So I think certainly, I don't feel strongly about changing the machine unless it weren't working. I think it functions the same, but you do need to change your mask, especially because the plastic starts to get soft and you can start to get leak from it. Is it worth retesting it? So, most of you are familiar, the Cpap, the doctor can get a download or a chip in the past where we had a sense of how well it was working in treating your apnea. So usually that gives the doctor a good sense of whether we really need to worry about it not being effective and you needing another sleep study. Certainly, there are some patients who, for example, have lost weight, and we want to know, especially if your sleep apnea was more mild to start with, whether you still need the device. And I think definitely in that setting, you could talk to your doctor about repeating the sleep study. Again, some patients who want a new machine, depending on your insurance, some will require a new sleep study for you to get the machine if you want a new machine. I've given up on trying to understand the insurance companies because they all have their own rules and they seem to revisit it every few years. So I will say from a medical perspective, I don't feel that you need repeated sleep studies unless there were changes in terms of how you were feeling or new symptoms, a lot of weight changes, or the machine downloads that your doctor is reviewing suggested your apnea is not being controlled.
Great. Thank you, Dr. Sunwoo. There's one more question. Just how does somebody get a hold of you to make an appointment to see a sleep doctor? Would it be directly through you, or what is the best way to get a hold of you, or to participate in a sleep study?
Yeah, so usually your primary doctor will just put a referral to our sleep center, and you will end up seeing any one of our group. Obviously, if you have a preference with one doctor, your doctor can request it. I do apologize up front. Our access is not great, but we're hoping that some of it unfortunately was COVID, but your primary doctor can at any point refer to the UCSD Sleep Center, and we would be more than happy to see anyone for any of the issues that we've talked about.
Wonderful. Well, thank you. I just got one more question. Give me one sec. This will be the last question for Dr. Sunwoo. My husband has very vivid dreams and can remember them in detail from people from his past. Is this normal?
Yeah, People always ask me, why is it that I don't dream, or others dream more? So dreams generally, again, as we mentioned, happen during that rapid eye movement sleep, which tends to cycle, as I mentioned, every 1.5 to 2 hours. I think a lot of whether you remember your dreams or not depends on whether you actually wake up during one of those periods. So if you wake up during a period when you're in REM sleep, I think that's probably why you remember sometimes whether you're dreaming versus whether you're not. Sometimes dreams can be vivid and nightmares can occur, and it depends really on severity and frequency whether you need to see a sleep doctor about it. For example, in San Diego, we have a big military population, and PTSD or post-traumatic stress disorder is common, and dreams can be very vivid and nightmares can be very prominent in PTSD. And in that situation, yes, it may be that you need to talk to a sleep doctor about treatments called image rehearsal and things to try and resolve it. So it depends a bit on any other symptoms that you may have, as well as the severity of your symptoms, but it's quite variable. But I will say, in patients who tell me that they don't dream, it's hard to really know if you're not dreaming. I think it depends a bit on at what phase you may be waking up in terms of your sleep cycle.
Wonderful. Well, thank you once again, Dr. Sunwoo, for this presentation. It was wonderful. Thank you to all of the participants, and we hope to see you back and join us for our next Distinguished Speaker Series and other programming. Find out all of our information at www.ljcommunitycenter.org. So thank you again, Dr. Sunwoo. Have a wonderful day. Stay safe, everyone.
Thanks, Nancy.